single Thursday. And for your questions, when we come to the question and answer session, please use that WhatsApp number that we usually give you, and it is +251 9455 02310. +251 9455 02310. You can also join us if you need to find an alternative channel. You can also try the African Union platforms, namely Facebook, YouTube, the live stream, as well as the African Union Twitter handle. For those joining on the Africa CDC channels, you can also try us on Facebook and YouTube. And we are coming to you, as I said, from the African Union. So today, Dr. John will give us a brief of the epidemiological situation and give us many other details on what is happening regarding COVID-19. But for now, I think let me give him the floor to start with his briefing. And then after that, we will go into the Q&A session. Dr. John, good morning, and you have the floor.
Thank you, Wayne, and good morning, colleagues. Good morning to everyone, and welcome to our weekly press briefing. And first of all, let me offer my sincere condolence on behalf of the African Union Commission to the people of Zanzibar for the death of their vice president that just occurred this week, His Excellency Sir Sari Ahmad. This again is a clear symbol that this pandemic is raging, and that the mortality during this second wave has been very, very severe and is continuing to affect people at a very individual level. As always, I will start with the epidemiological update and then segue into the support that Africa CDC continues to provide to member states, and then of course, we'll discuss vaccines, and we'll begin a new series today by giving you an update on the Ebola situation that we are also engaged with in the Democratic Republic of Congo and in Guinea. So let's start with the epidemiological update. As of 9 a.m. East African time today, the world has recorded 109 million cases of COVID-19, and with a death rate of, or total number of deaths of 2.4 million people worldwide, representing a case fatality rate of 2.2%. In Africa, as of today, the continent has reported a total of 3.7 million cumulative cases, of which represents 3.5 total cases globally. Of that number, the good news, as always, is that 3.3 million people have recovered, and that is about 88% of the total number of cases infected and versus recovery. In terms of that, we as a continent have reported a total of 99,840 deaths, with a case fatality rate ratio of 2.6%. And this represents 4% of the death rates reported globally. So we see we are edging towards 100,000 number death rates, which again, if anyone had told me 1 year ago that we as a continent within 1 year will be seeing 100,000 deaths from a new infections, I would probably not have believed that, but here we are in that scenario. With respect to the variants, and with a focus to the 2 new variants, and going forward, I would not use the word, I would not associate a country to a variant, because we at Africa CDC have taken an exception of characterizing a variant like to belonging to a country or country of origin, because again, we as the global health community have also agreed that it wasn't appropriate to be linking the COVID-19 virus. So again, I will use the word the 501YV1 variant and characterize it that way, and then the 501Y V2 variant to distinguish the two. So I think the most important thing is the V1, V2 variant. The V1 variant has been so far reported in the Democratic Republic of Congo, Gabon, Gambia, Ghana, Morocco, Nigeria, and Senegal, and South Africa. The V2 variant, that is the 501Y V2 variant, has been reported in 11 countries in Africa, and that is Botswana, Comoros, DR Congo, Gambia, Ghana, Kenya, Malawi, Mozambique, South Africa, Zambia. So in terms of the number of countries that are reporting close to 70% of the total caseloads, they include the top 5 in Africa, South Africa representing about 40% of all the infections on the continent, Morocco 13% of all the cases on the continent, Tunisia 6%, Egypt 5%, and Nigeria 4%. The case fatality ratio, again, our case fatality ratio continues to be above the global average of 2.2%, and 21 countries, that is 38%, are reporting case fatality ratios that are more than 2.2%. I will not read all of them. So let's go look at the trends. So last week when we met here and we compare what we have observed with what observed over the last 1 week, what are we seeing? Between February 8 and 14, we have recorded 99,710 new cases. And this represents a 25% decrease of new cases over the last 1 week. That is our epidemiologic week number 5. We've also seen the similar trends for deaths, where over this last week, we observed that a total of 4,102 new deaths were recorded across the continent. And that also represents 28% decrease compared to the previous week, week 5. So I think overall, from last week to this week, we are seeing some encouraging trends, and we are really pleased with that. Countries to do highest proportion representing 41% that are reported cases of South Africa, Zambia, Nigeria, Tunisia, and Mozambique. So if we now look at the trends over the last 4 weeks, and which will give us an overall better trend tendency, we see that between January 18 and February 14, we have recorded an overall average decrease of 21% in new cases across the continent. And if we now look at the continent by region, we observe a 29% decrease in Southern Africa, 18% decrease in Northern Africa, 3% decrease in Western Africa, 1% decrease in East Africa, and 1% increase in Central Africa. That is the trends over the last 4 weeks. If we now look at the 5 most populous countries, over the last 4 weeks, we see some differences across as following. Egypt, average 10% decrease. Nigeria, 13% average decrease. DRC, 17% average decrease. South Africa, 38% average decrease. Kenya, a slight ticking up over 5%, and Ethiopia about 16%. So that is the epidemiological trend so far. Let's now look at the testing. Overall, as a continent, all 55 member states have now conducted a cumulative number of 34.6 million COVID tests. and with a overall positivity rate of 10.9%. 42 member states have a test positivity rate of above 5%, which is still a lot of cases going out there. As we announced last time, we as the Africa CDC are really actively working to roll out the antigen test, which member states are uptaking, and we are also continuing to roll them out and support member states to increase that level of testing, because we believe that is rapid, is more is scalable, and is easy to use, and it gives you SARS-CoV-2 sequences have been uploaded on the national portal to monitor the circulation. On this, let me just add that our CDC is to expand this to about 50,000 months. And hopefully towards the quarter, we should be able to achieve this target. Again, it's a goal we are setting, an ambitious goal we are setting for ourselves, but we have to do that in order to better understand what is going on across the continent. For the epidemiological week 6, that is between 8 and 14 February, 915,000 new tests were reported. And this represents a 14% increase in compared to the previous week that we observed 800,000 case tests conducted. So that is in terms of the testing. Let's just go over a few other capacity building activities that Africa CDC is doing. We are conducting management to support member states through webinars to 42 clinicians across member states. Infection control prevention courses are continuing. We continue to enhance member states with those in those areas there, and also developing advisory protection notes on respiratory protection equipment. Now, on vaccines, to conclude the COVID section, as we announced previously that through a partnership with MTN Mobile Telecom, they generously donated $25 million to support vaccination of healthcare workers. And I'm pleased to announce that the delivery of the first 1 million doses across the continent will start from next week. We are hoping that before next Friday, that delivery will start going out to member states. And that will be the first attempt to try to reach out to about 20 countries with vaccines. And then at least that will enable us to start vaccinating our healthcare workers and also learn from the process by doing it. So we are very excited with that prospect. The Africa CDC is also putting up as quickly as possible a COVID-19 dashboard for monitoring vaccine rollout, which will go live hopefully soon, so that each time you can go on that dashboard to at least acquaint yourself with what is going on. With respect to the overall AVAT, which is the African Vaccine Acquisition Task Team efforts, last week a colleague wanted to know how many countries have submitted the applications and what doses there. So we promised to come back to you this week, and we are here to say that 26 countries have submitted their applications, and resulting to an overall number of doses tallying to 180 million doses there. So again, remember the process will work as follows. I mean, countries will submit all their requests. The deadline was 15, and those will be picked up by the Afri-Exim Bank, and then the arrangement will start from there. And once they finalize the financing arrangement, the delivery will start. So let me conclude on that, and then ask that we transition to very briefly to the Ebola situation in two countries there. And I would like to invite Merawi to come up and give us an update on where we are with the Ebola situation in both countries. Merawi, just by way of introduction, is the incident manager for Ebola response in both the DRC and than Guinea. Dr. Mirawi, please, over to you.
Thank you, Dr. John. Good morning, good afternoon, wherever we are. I just want to give you just a brief highlight about the current Ebola events in both two countries, DR Congo as well as Guinea. So DR Congo, it is a 12th disease outbreak. It was declared on the 7th of February 2021 in North Kivu province in Butembo area. This area was the epicenter for the last 2 years for the ongoing outbreak for about 2 years. It was declared over in June 2020. As of 9 a.m. East African time today, 4 confirmed cases with 2 deaths with case fatality rate of 50% have been reported in these 2 health zones in North Kivu, Biena and Katwa health provinces. So far as a response, a total of 369 contacts have been listed, 326 of which are currently being monitored. 69 eligible contacts have been vaccinated, and the government of DR Congo, Ministry of Health, is working in with partners, including Africa CDC, to establish a coordination mechanism to respond to this outbreak event in DR Congo. The next is Guinea, Ebola outbreak in Guinea, which was declared on the 14th of February, following the detection of the days of following in Goke Health Center. As of today, 8 cases, 3 confirmed and 5 probable cases, with 6 cases resulting with case fatality rate of 75% have been reported in 2 regions. And in Conakry, 1 case, and in Zerekore, 6 cases with 5 cases. Suspected cases, around 10, are currently being monitored with laboratory. Genome sequencing was done, and it confirmed the Ebola virus species. As a response, 125 contacts, of which 115 are in Zerekore and 10 in Conakry have been listed, and almost 95% are currently monitored. As Africa CDC, when we had this outbreak on the 14th, we immediately contacted the Ministry of Health of Guinea, and we start coordinating as a region, and we immediately activate our emergency operations center, and we deployed advanced team of experts to support the national emergency plan development, as well as regional need assessment to support the whole of the region. And we also did, in collaboration with the regional health organization, WAHO, we had 1 regional meeting conducted on Monday. And that's really gives on board, brings on board both different high-level representatives, including ministers of health of neighboring countries and WAHO regional organization, as well as the REC ECOWAS. So now we are working toward supporting the whole region to strengthen the whole of the region to respond to this outbreak. Currently, this time, the good news is we have all the ammunitions, including vaccine, therapeutics for this outbreak, and we hope we'll control it with the shortest time possible. Thank you.
Thank you, Mirawi, and Wayne, over to you.
Thank you very much, Dr. John, and Dr. Mirawi. It's lovely to see you again. Our first question for today is coming from Coletta Wanjohi, and she's with FSN. She has 2 questions, but for now, I'll give you 1. She says the WHO and the Africa CDC seem to have issued conflicting guidance on the use of the AstraZeneca vaccine, with the WHO encouraging its continued use even in areas with the V2 variant, while the Africa CDC prepare to roll out other vaccines. Isn't this confusing for member states?
So, Coletta, thank you for that very important question. I mean, the first thing we should do is to actually recognize and celebrate the great progress vaccines in a short test possible time of 1 year, a whole variety of vaccines. And I say this as a virologist for almost 3 decades, knowing the experience from HIV, that it is very possible that these viruses can challenge us in a way that you don't even have a vaccine even after 40 years, like for HIV. So to have come out with vaccines against COVID-19 virus for just 1 year is something that we should celebrate. It's a different issue from access. Now, the second thing that is more specific to your question is the guidelines. I don't think we issued conflicting guidance there. I think what we did was more cautionary approach. We said, one, the AstraZeneca vaccine is safe, very safe. 2, the AstraZeneca vaccine works very well. It's very efficacious in areas that we know that there are no variants. 3rd is that as a precautionary measure, based on the limited data that was generated and shared in South Africa on about close to 2,000 participants, that it was preferable that if you have the options like South Africa does. I mean, South Africa has now imported the Johnson & Johnson vaccines to go with that vaccine that is that has been shown to have an impact on the severe cases of the virus. So that is not totally contradictory. I think the WHO took a more a slightly different approach that says, well, I mean, the data is still preliminary. You can still go ahead and use it. But I think if you recall, what the South African government did was to temporarily put it on hold, and not to say they would not use it at all based on waiting the final outcome of a large-scale study, and which we ourselves at Africa CDC will be designing studies to try to obtain information on whether this vaccine is efficacious in decreasing the severe cases of COVID infection. So it's not contradictory at all. Again, keep in mind, we are learning how this virus behaves. We are learning how these vaccines behave vis-a-vis the new strains, and we continue to use a very cautionary approach to this. It has nothing to do with safety. I mean, if I was offered an AstraZeneca vaccine today, I would take it, okay, very, very quickly. So I just don't want the population to get confused that that something is wrong with the AstraZeneca vaccine. No, we are saying that because of the limited studies that we saw in South Africa, it's better to take extra cautions in not rolling that out if the variant is available at the scale which it is in South Africa. I don't know if that makes sense.
Thank you very much for that. Now, Coletta had a second question, which has a number of parts, but this second question is related to one that is coming in from Sophie Mukwena.
You do just that. That is what we issue. Now, with respect to South Africa, other countries looking at that, we are engaged with other countries in a totally transparent manner. We offer them, so these vaccines are not different from those that we have ordered through the platform. Okay, remember that our platform, when we announced that we have secured 270 million doses of vaccines and an additional doses to come next year. The AstraZeneca vaccine is part and parcel of that, and we are still going ahead with that. So these vaccines are not different from those that we have ordered on the platform. So again, the notion that South Africa has rejected the vaccines and then we are shipping it to other countries is really not accurate. So Sophie and Coletta would really ask that we count on you to transmit this message with clarity to the population, because I think there will be, there's need to clarify that. I fully understand that it can be challenging for people to understand what is going on. So the African platform, the AVAC platform, will negotiate with South Africa and obtain these vaccines, not for free of charge. Again, we will obtain it as negotiate with the government of South Africa to purchase these vaccines and then just add it to the already stock that we had arranged through the platform. So it's not a donation. It's, I mean, these are good vaccines. These are safe vaccines, and we have absolutely no problem with that. Again, we are not forcing countries. We put it out there for countries to decide if they will receive their doses or not receive the doses. But again, remember that on our platform has 3 different vaccines. One is the Pfizer vaccine, the Johnson & Johnson vaccine that will come later, and then the AstraZeneca vaccine. So again, it's not new vaccines. It's not something different. It's the same vaccines that we will be having through the platform.
Thank you very much. I'm glad you've clarified that point, because there was a lot of talk on it on many WhatsApp channels over the past few days. So that clarity is really important. We move on now to a question, 2 questions coming from colleagues who are online. And the first one is Paul Adepoju. Paul, good morning.
Good morning. Thank you very much for this briefing. So I'd like to start with an update on the Ebola outbreak in both countries. I want to know how many doses of the Ebola vaccines are available for DRC and Guinea in the present outbreak. Then my second question is that with the February 15 deadline for expression of interest for African countries to order the COVID-19 vaccine via the platform now over, what do you think is responsible for more than half of African countries not making use of the platform? And are you planning to extend the deadline? Well, my last question is that in which African countries are the V1 and V2 strains the major circulating strains that are directing the epidemic in these countries? Thank you very much.
So thank you, Paul. Many, many questions. Let me start with the most recent ones and work backward. Again, what we are doing with the platform, the AVAC platform, that is the African Vaccine Acquisition Task Team, is to offer options to countries. It's very possible that countries want to, first of all, start with the COVAX mechanism and secure vaccines from that mechanism. We just don't know. We've done all we can to engage countries, explain to them using different avenues of communications to point them to the platform. And we will see what happens as we move forward. But it should be very clear that COVAX has said very openly and from the beginning that they will support the continent with about 20 to 25. Initially, they said 20. Now we understand 25% of the vaccines. I have said repeatedly on this platform that vaccinating a country with, at a level of 20% or 25% will not get the pandemic out of their country. There is absolutely no way that will happen. We need to strive at higher levels of about at least 60 to 70% vaccination. That's why we set a continental target at 60%. So we are just, so if we assume that COVAX will enable us with 25% of our needs, we still have a gap there to get to our 60%. So again, we encourage countries to look into this very carefully and take advantage of the platform to meet their country targets there. So we fully understand that this is a phased approach, and we are also saying as a continent that if we really want to be ahead of this pandemic, we should strive to vaccinate 35% of our population by the end of the year, so that we begin to really create a serious chance and opportunity that this war against the COVID-19 can be won. I think that is one. With respect to the Ebola vaccines, we are not in a position now to tell you exact with specificity what doses of vaccines are going into DRC or Guinea. We are in discussions with the manufacturers. WHO is taking a lead on that. And we will be working with WHO very clearly to coordinate our efforts in the coming days. Again, it's still very early in Guinea. We have a team that has already arrived in Guinea. Another team is going to leave Dakar at the Institut Pasteur, joining with us in the coming days to be deployed in the theater of response. And we, as you heard from Dr. Mirawi, we are also discussing with the ministers in that region to coordinate our efforts and come out with a regional approach together with the West African Health Organization. So all of that, early days of this outbreak, and we'll continue to update you as we learn more. I believe there were a series of questions, but I believe that we have addressed most of them.
All right, thank you. We also have Julia Paravicini, who's online. Julia, good morning. Hello, Julia. Julia is from Reuters. I think she's still trying to connect with us. Julia, your microphone is muted. Yes, good morning, Julia. Please go ahead.
Good morning, John. Good morning, Winnie. So my question is, a new study suggests that the South African variant of the coronavirus may reduce antibody protection from the Pfizer-BioNTech's vaccine by 2/3. And this is the next vaccine due to arrive in South Africa with about 500,000 doses expected initially and about 7 million by June. So following the findings of this new study, what does the CDC recommend should South Africa do?
So let me say this, that in vitro studies, studies conducted in the laboratory with all these vaccines, and underlying in vitro studies showed that these new strains affect the ability for this virus to be neutralized at different levels across the different vaccines. I think this is not just unique for AstraZeneca or for the Pfizer and Johnson & Johnson. The in vitro studies clearly shows that there's an impact there, by varying degrees. So the reason the in vitro studies has also indicated that AstraZeneca is affected the most in vitro by several log-folds of reduction in neutralizing antibodies there. So it is not just for Pfizer, but what matters is that what is this level of reduction? Is it a significant reduction or just a moderate, a slight reduction? I think most of these vaccines that you indicated, the Johnson & Johnson, Pfizer, and I think the Novak vaccine is slight reductions. It's not up to a log. A log means that it will be several fold, and that means that you require a lot of neutralizing antibodies to be generated in order to protect the individual. So I think I would still suggest that based on the in vitro studies, again, I underline that South Africa can still go ahead and use these vaccines, because what we are seeing based on the studies is not like a huge changes in neutralizing antibodies to this virus. But let me just also conclude by saying that we don't know what these in vitro studies mean in terms of clinical. That's why I keep underlining the word in vitro. We don't know what in individuals that will also translate into ineffectiveness of the vaccines, for simple reasons that a vaccine will induce two arms of protection. One is the antibody arm, which generate antibodies to the B cells, and then they bind to the virus and stop the virus from replicating. It activates the ability for the cells to be all over the place and then target those cells that have been infected and kill them. So, but we don't know what this other arm is doing. So that is why we cannot only rely on the antibody part of it. We have to look at clinical to really say that, well, this mutant is having an effect on the effectiveness of a virus. I think understand there are two arms that that operate to provide protection.
Thank you very much for that. We move on to Nairobi now, and we have a question that's coming from ZDF German TV. The writer doesn't put their name, but they are with us quite often. So the question is, do you have an idea when and where the first large-scale vaccination campaign will start in sub-Saharan Africa, apart from in South Africa?
I do not have an idea of where the large scale will start. We know that COVAX is working very hard to ship out vaccines by the end of this month. I've also stated that AVAC is trying to roll out vaccines as quickly as early as next week, but whether they actually become large scale, I think we should wait until the beginning of April or so to see how these doses will be introduced onto the continent. At the same time, what is more important in our view as Africa CDC is the preparedness. How do we prepare countries so that they are very ready to get started quickly and start the rollout process once the vaccines become available?
Thank you, John. Now we go to Abidjan, and Katarina Hohi with Bloomberg has two questions. So she says, this is about the Ebola outbreak in Guinea. How serious is the threat that Ebola could spread in West Africa? What will it mean for countries that have already been battered by the coronavirus epidemic in terms of their ability to respond to Ebola? So those are the two questions from Katerina.
Two very good questions. I mean, let me start with the first question, which is how big is the threat? Have been identified. And if you look at exactly on the map where it is located, it has the potential to really spread into the Liberia, Guinea, and Sierra Leone. And because of the movement of people across that area, I mean, there's a lot of movement across that area. And you also recorded Cote d'Ivoire is a neighboring country. I mean, so there's all that, I mean, it's all about movement of people. And I think it offers that threat very, so much so. But with respect to, are we better prepared than we were 5 years ago? Answer is a big yes. We are better prepared. I mean, first of all, we are already so mobilized. As you heard from Dr. Merawi, we've had meetings at a regional level where 4 countries, together with the West African Health Organization and Africa CDC, had a coordinating meeting already on Monday. As early as Monday, remember, we knew about this on Sunday. On Monday, we were already coordinating. The West African ministers had a meeting on Tuesday, and it was all about COVID and Ebola. So I think that is just, so the awareness is and preparedness now is so much higher than it was 5-6 years ago, where it took about 3 months to 4 months to even recognize that there was something going in there. So that is one. Second, you heard from Dr. Merawi that we are better equipped today with biomedical interventions than we were 4 or 5 years ago. We have monoclonal antibodies that work. We have 2 vaccines that work very well. And I think and those products and tools are ready to be deployed anytime in the theater of response. Lastly, in terms of community engagement, is not a naive community anymore. When Ebola hit that region 4 or 5 years ago, it was totally new to the community. They didn't know what it was. And there was it took a lot of cultural and anthropological aspects to bring people in the community to understand what was going on. Now they understand what is going on. So I think I'm very convinced that I remain very optimistic that with all this combination of all these factors, we can actually make an early inroad into the fight against Ebola in that region. I mean, absolutely no doubt. Is the the presence of COVID a positive or a negative sign? It depends on how you look at it. I believe I'll characterize it as the glass half full or half empty. So the glass, you can see that as half full because we already have a lot of public health assets in the region. Okay, in Liberia, Sierra Leone, Guinea, we have community workers that are already there that we were supporting to engage in COVID response that we can easily repurpose on and redeploy to move that into the theater of response for the Ebola outbreak there. So I think that much you can see it as the glass being half full. You can see it as a glass half empty if you say, well, maybe this will impact the response on COVID-19. But overall, we have assets in the theater of response. It's not, we are not going to start from zero.
Thank you, John. Sarah Jerving with Devex says, you have spoken about 1 million doses that will be provided from MTN. I think she meant to say 7 million doses there. So the questions that she has, the first one is, what type of vaccines will these be? And secondly, will they be distributed among the 20 countries equally? And then thirdly, what day will countries be receiving them? And also, can you name the countries that will receive these vaccines?
From Sarah, but let me say that they are, let me just clarify a little bit here, that the MTN donation is targeting 7 million vaccines. And of that, of course, you always have to start somewhere. The first 1 million will be ready for distribution as early as next week, we are hoping. Okay, I mean, keep our fingers crossed that all the logistics come in place so that we can start shipping them out. Second is the distribution formula. We have a formula in the platform, and again, you can all go into the platform amsp.africa and see how these vaccines are being allocated based on population size and other parameters. They are all they are not distributed like equally, but distributed according to certain formulas, including, population size. I think that is all public information. Thirdly, these vaccines are the AstraZeneca vaccines, which I've said over and over that they are safe, they are efficacious when used, at least based on early data in populations that are not predominant by the variant, the variant that was recognized in C2. It's just how many countries? I think there are about 20 countries that how far you go. See, continuous process until we hit the 7 million target that MTN had supported.
Thank you for that. Bonisile Makubu from the Times of Eswatini says, what is your take about individuals who fly out of their countries to go, for example, overseas to take the vaccines? Then secondly, she says, what advice can you give about remdesivir injections, which some people are taking to treat COVID-19?
About concerning the first question, whether people flying out of the countries to get the vaccines, I believe that countries have outside of Africa have very strict criteria on how to sequence the vaccines. I think that in most countries they start with the healthcare workers and then populations with underlying diseases, the elderly. So I don't know how. I mean, I'm not in a position to describe the behavior of these people and where they are going and how they are getting into line or cutting the queue to get the vaccine. So unfortunately, I cannot help with that answer or that question, rather. With respect to The second question was more on, if you can just repeat that, please.
All right. It was about...
I didn't get the injection. The injection part was...
Yes, so she's asking, what advice can you give about the remdesivir injection, which some people are taking to treat COVID-19?
Remdesivir is a drug that was early on thought to have an impact on the clinical outcome, and where after clinical studies, where it actually showed that, and it's published, that it didn't really have a major impact on the clinical outcome of COVID-19 patients. And I don't think that is being, and this was the WHO, part of the WHO solidarity trial. And so I've not seen any further details on that molecule. And what we know is that early on, it was one of those very early drugs, and the studies didn't find that through clinical trials to be that effective in managing severe cases.
Thank you very much. Before we move on to the next question, we are having colleagues here asking about the link to the website that you've been talking about. So I just want to announce that it is amsp.africa. So for colleagues who want to consult that website, please go to amsp.africa. We move on now, and we have a question from Peter Mwai from the BBC. And Peter says, on the vaccine doses that you hope to be shipping to countries next week, will they be AstraZeneca? With South Africa.
So these vaccines, Peter, are the AstraZeneca, the same source that shipped the doses to South Africa. So I really want, I really need your help, you and Coletta and Sophie, to make sure that our population out there understand that it's one source of vaccine that we are getting from the serum, and this is a safe vaccine. And this vaccine is efficacious against other variants. So we shouldn't, the point I'm making is that it's outside of South Africa, and then you can we should not use that one and only get the one from India or whatever. No, it's not. It's the same vaccine from the Serum Institute in India.
All right, thanks. Sarah Jerving has come back again with another question, and she says, can you talk more about the Ebola cases that were reported in Conakry? What is the significance of cases discovered in urban areas? Dr. Merawi will take that.
Yeah.
Yeah, thank you very much for that question. That is very important as it happens in a major city. This is a contact person who traveled to that area. It is a contact, the same contact from Zerekore that traveled to the other, but he was captured, isolated, and the contacts are traced. Around 10 people are being monitored. So yes, it has traveled to a major city, and the risk is there, but fortunately it was controlled early and captured and isolated, and contacts are traced already. Thank you.
Thank you for that. Perhaps we are running out of time, but we have one more question, and it is regarding the Sinopharm vaccine. The question that's coming through is that there are suggestions that this vaccine has not yet completed all the 3 trial stages, and that Africans are being used to complete these trials. What would be your comment on that?
No, Africans are not, as far as we are aware, this vaccine was tested in, I think, Morocco, and trials in Morocco and Egypt. And we've engaged all vaccine manufacturers as Africa CDC to share with us their dossiers so that we can use regulatory processes that we put in place. And I did announce on this forum a few weeks ago to review the dossiers and look at safety aspects as well as the efficacy aspects of the vaccine. So again, we are very open to, or we've received dossiers from the Gamaleya vaccine, the Sputnik 5 vaccine. We've also in discussion with Johnson & Johnson. So we are really open as a continental public health agency to review all data from all vaccines so that we can all align and inform the public accordingly.
Okay, thank you very much, both Dr. John and Dr. Merawi. It's time now to make your concluding remarks, just giving us those headline points that you want people to take away from this briefing today.
So thank you, Wayne. And first of all is the overall trend of a pandemic, that the 25% decrease that we are observing over the last week. And if you look at that over the last 4 weeks, it's a very good sign in the good direction. And again, it speaks to the fact that there's a whole coordinated whole of society approach, which means that we are doing something right. And we need to continue to do those right things, which is masking, avoiding crowded areas, or even including indoor gatherings, and of course, hand hygiene and the community really showing leadership there. That is the only way that we are going to continue to fight this pandemic until when vaccines are available at scale. I think that is clearly a positive sign, and very encouraged with the direction that this is that what we are seeing. Having said this, we all know, and we warned earlier on during the first wave, that this is a very tricky virus, and it spreads. I mean, I have not known a virus that has infected more than 100 million people in 1 year in the last, in my whole career. I mean, that is my almost 3 decades career. So we take it seriously that at any point it can come back. So it means we cannot be complacent at all while waiting for vaccines to arrive. Second message, and this is an appeal to all of you, is that to help us communicate the situation of the AstraZeneca vaccine in South Africa, that it is not a bad vaccine. It is actually a very efficacious vaccine if used in the right context. And you go to war with what you have and not what you need. And also that they are, in the coming months, you have the landscape of vaccines will continue to improve. I think that South Africa is not dumping this vaccine on the rest of the continent. It's just the same source of vaccine that we are getting from the Serum Institute. South Africa has been extremely transparent in, first of all, telling the world that there was a new variant. And then secondly, sharing early studies that this virus may be behaving differently with respect to the AstraZeneca vaccine. So communicating that to the public in a way that is assuring and that this vaccine will still be a very useful tool in a fight against the COVID-19 outside of South Africa will be a very helpful contribution, because we find ourselves in a situation where we have to fight this pandemic aggressively. And one of these vaccines that are available for almost immediate use is the AstraZeneca vaccine. So if we do not create appropriate communications around that vaccine, then we may end up really impacting negatively our ability to fight this virus. And again, in the spirit of the whole of society approach, we're counting on everybody, policymakers, political leaders, civil society, the media, and of course the public health experts to communicate this information as best as possible to the general public. Those will be my ask for this conversation or this platform today.
Thank you very much. That was Dr. John, the director of the Africa CDC. And today he was joined by Dr. Merawi, who's also with the Africa CDC and who gave us information and details about the Ebola outbreak in the DRC and in Guinea-Conakry. Thank you very much, colleagues. I also want to thank those who've been behind the scenes, making this whole thing possible. And lastly, to thank you, colleagues, for your interest and your continued determination to continue to raise awareness around these issues of public health on our continent. So thank you very, very much. This is it for today, but we will be back with you again as usual on Thursday at 11 a.m. East African time. For now, from all of us here, bye-bye.
Thank you so much, and see you next week.